Now, for those of you who have been paying attention to our list of 5 types of treatment we discussed at the very beginning of this chapter, you may have noticed that we have been missing one. So let's backtrack a little and talk about our biological approaches to treatment. Now, this section is talked about separately from all of the other types of treatment that we mentioned earlier in the chapter because our biological approaches are very different. It's not a relationship between a therapist and a client. It's not sort of talking through or working through particular problems. Instead, this is just the biology that's underlying potential psychological disorders. So these are going to be emphasizing those biological factors. Things like the neurotransmitters in our brain are especially important when it comes to treatment that is biologically based. So we're going to focus specifically on drug therapies, electroconvulsive therapy, and psychosurgery as our 3 broad types of biological approaches. And the largest or most common of these is absolutely our drug therapies. They are the most commonly used biological interventions. And so the field of psychopharmacology is the study of how drugs affect cognition, emotion, and behavior. So how do different substances that we can consume or bring into our bodies change how we think, feel, and act? And of the 200 million psychopharmacological prescriptions that are written each year, the majority of these are written for anti-anxiety, antidepressants, and antipsychotic drugs. So those are our 3 broad categories that come up most often. So we're going to talk about a couple of these. Now, before I actually start on antidepressant drugs, I want to spend just a brief second on the anti-anxiety drugs. So we have some very common ones. So anti-anxiety, sometimes called tranquilizing because they're doing that calming effect. And so the most common ones that you may have heard of would be Valium, Xanax, and Buspar. I think Buspar is only mentioned because it's a newer type of drug that's sort of slowly taking over for anti-anxiety medications, just because it acts a little bit more slowly. It has longer lasting effects, and it seems to have fewer negative side effects than some of the other more commonly used drugs. Because if we think of these as tranquilizing drugs, things that help calm and relax us, it makes sense that they're going to be highly addictive and they could cause some pretty nasty withdrawal symptoms as people stop using them. But for the most part, these tranquilizing drugs, these anti-anxiety drugs, tend to work by slowing down our excitatory synaptic activity within our nervous system. And one of the mechanisms that they think they're using to do this is to enhance the postsynaptic activity of GABA. But enough about anti-anxiety drugs. We're actually here for antidepressant drugs. And so we're going to talk about 3 categories of antidepressant drugs. Tricyclics, the monoamine oxidase inhibitors, or MAO inhibitors, and then selective serotonin reuptake inhibitors, SSRIs. So let's start with our tricyclics. So tricyclics are going to increase the activity of norepinephrine and serotonin. So those are the 2 neurotransmitters that are most important with the tricyclics. Now, they increase this activity by preventing the reuptake of those excitatory neurotransmitters. Now, I'm going to make you remember all the way back to Psych 104 yet again, and we're going to talk very, very briefly about our neurotransmitters and how they fire again, just so that this makes a little bit more sense. So you might remember from 104 where you would have picture of a neuron kind of looking like this. You've got your little branchy bits at the top here, and this would be your cell body. So this is where your nucleus is, and we have our dendrites and our axon, and then our axon terminal. So down here is where we'd have all of our neurotransmitters being released. And so our signal's going this way. And so this axon terminal is going to be releasing neurotransmitters into the gap between this cell, this neuron, our presynaptic neuron. And it's called that because it's before the synapse, before the gap between the cells. And it's going to be dumping it into the space that connects it to our next neuron. So this is our next cell so that the signal can keep going there. So we're looking at the synapses here. And so the process of these cells communicating between each other is that this one is going to release a neurotransmitter into that gap. The neurotransmitter migrates across the gap and connects to receptors on the other side, on the postsynaptic neuron, so the cell that comes after the gap. And then it's going to stimulate this cell to either excite it or inhibit, so excitatory or inhibitory neurotransmitters. So our excitatory neurotransmitters make the second cell, our postsynaptic neuron, more likely to fire. So if this tricyclic is preventing the reuptake of excitatory neurotransmitters, it's messing with the process where after these neurotransmitters are dumped into the synapse, they're dumped into that space between the cells, there's a process called reuptake that will collect those neurotransmitters after a certain amount of time has passed. So after this cell has released all of its neurotransmitters, they should eventually get cleaned up through the process of reuptake. But these tricyclics prevent reuptake, so they prevent the cleanup, which just means that those excitatory neurotransmitters that we're talking about spend more time in the synapse, they spend more time in that gap, and therefore activate this downstream cell, this postsynaptic neuron, for a longer period of time than they would have otherwise. So this is just increasing activity in the next cell. And so kind of related to this are monoamine oxidase, or MAO inhibitors, are drugs that inhibit the monoamine oxidase, which, if we look at the root here, an oxidase with that ASE at the end is usually telling us that it's involved in the process of breaking something down. And in this specific case, our monoamine oxidase is breaking down the neurotransmitters. So normally, the neurotransmitters that are dumped into that synapse, they're either recollected by the neuron, so they're either reuptaken, or they're broken down and recycled. And so that breakdown process would be controlled by this monoamine oxidase. So if our MAOA inhibitors are preventing this process of breakdown from happening, then it's going to be increasing norepinephrine and serotonin, yet again, so the same process. But instead of stopping the recollection of them, in this case, it's going to stop it from being broken down. So again, we're just having more of the norepinephrine and serotonin in the synapse between those cells. It's going to be functional for longer because it's not getting broken down, it's not getting removed from that gap as quickly as we would expect normally. Now for our third category, we can talk about our selective serotonin reuptake inhibitors, or SSRIs. And very similar to the other ones we just talked about, these ones are blocking the reuptake of serotonin. So serotonin would be a neurotransmitter. It gets dumped into that gap between the two neurons. And if you are taking SSRIs, then that reuptake process is going to be much slower. So there's more serotonin available, there's more serotonin between the two cells, so it is more active. And so I actually have an image on the next slide that is specific to SSRIs, but it's showing a properly drawn version of what I scrawled on the previous slide. So here they have A would be someone not on SSRIs, where our presynaptic neuron, the one that was ahead of our synapse, the head of the gap, releases the neurotransmitters into our synapse, into that gap between the two cells, and the serotonin would fit into the postsynaptic neuron's receptors and trigger that postsynaptic neuron in some way. This process of reuptake is where the serotonin is removed from these receptors and collected and brought back into our presynaptic neuron. So normally, this process happens fairly smoothly. When you're on SSRIs, they would block this process of reuptake. So instead of allowing those neurotransmitters to be recollected and recycled, they would keep them in the synapse where they can keep activating the postsynaptic neuron. So they're active for longer. So despite the fact that all of these types of antidepressant drugs seem to function in fairly similar ways, SSRIs are becoming a lot more common, and they're slowly starting to replace the other types of antidepressants. One of the major reasons for this is that there are a lot milder side effects with SSRIs than with the other kinds. And they also seem to be really effective at reducing depressive symptoms a lot more rapidly. So the effects are a lot quicker, and the side effects are a lot less, which is why you see a lot of SSRIs being used now, and fewer of the other types of antidepressant drugs. Now we're going to move on very, very briefly to antipsychotic drugs. And antipsychotic drugs are perhaps one of the most dramatic effects of drug therapy that we've seen in recent time, where it's allowed for the treatment of individuals with very severe disorders who may not have been able to function normally in society without this treatment. So antipsychotic drugs decrease the action of dopamine. And you may recall that the overactivity of dopamine is thought to be involved in schizophrenia. We talked about the dopamine hypothesis of schizophrenia. So by reducing dopamine levels, we can reduce a lot of the positive symptoms of schizophrenia. And so we had talked about positive and negative symptoms for schizophrenia, and the positive ones are where you're experiencing things that aren't there. So you're experiencing too much of something. So things like delusions and hallucinations. So by reducing those symptoms, you're allowing people to go out and function in the real world. Unfortunately, these kinds of drugs tend to have very little effect on negative symptoms, so they don't do much to help things like immobility or inability to talk or catatonic states, that sort of thing. But they do tend to help positive symptoms fairly dramatically. The one major downside that sometimes gets seen with taking these kinds of antipsychotic drugs is called tardive dyskinesia, which is a very severe movement disorder, and it leads to sort of grotesque movements of the face and tongue, is how they describe it. But very dramatic movements of the face, which are uncontrollable and especially prominent in people who have taken antipsychotic drugs who develop this disorder. And especially troubling is that once this disorder has developed, there is no way to get rid of it. So once it happens, it's not treatable, it's sort of there to stay. And sometimes when this disorder develops, it can be even more debilitating than the original disorder that the antipsychotic drugs were taken to try and treat. And the scariest part is how common it is. So within 4 years of beginning antipsychotic medications, about 20% of young adults and 30% of those over the age of 55 will develop symptoms of this disorder, which is massive. That is a huge portion of people who take these drugs that experience that massive downside. And so, of course, current research is working very, very hard to try and find an equivalent drug that would sort of get the same effects without the potential for the downsides, without these negative side effects. And this is how they've come up with a new drug, or relatively new drug, called clozapine. And it manages to reduce positive symptoms, just like the ones we just talked about. It also seems to help reduce negative symptoms. And it definitely does not produce the same movement disorder, but it comes with its own set of negative side effects, including a fatal blood disease that shows up in 1 to 2% of people who take it. So again, there are lots of potentials for benefits to try and reduce some of these really crippling symptoms, but the side effects are so detrimental that it's such a risk to go on these medications. So individuals who choose to be on antipsychotic medications, or who end up having to be on antipsychotic medications, need to be made aware of all of those side effects, the potential for things to go wrong. Now, despite all of these negatives that we just talked about, we can see that, let's walk through this graph to explain the point. But here we have the number of hospitalized inpatients, so individuals that were restricted to psychiatric hospitals due to some kind of disorder. And then on the bottom here, we have time. So in the 1950s, we hit this peak of more than 500,000 individuals who were being hospitalized for psychiatric disorders. But the development of antipsychotic drugs in the mid to late 1950s is what precipitated this massive drop-off in number of hospitalized individuals with those psychotic disorders. So even though there are lots of negatives that can happen with those disorders, it does help give a large number of individuals the potential to live outside of the hospital and experience relatively normal lives, mostly unaffected by their disorders as long as they remain on their medication. So these drugs, despite their negatives, do have the ability to allow some people to leave mental hospitals and live their lives. Our next category of biologically based treatments is a rather controversial one, and this is electroconvulsive therapy. So the existence of electroconvulsive therapy began when individuals started observing that schizophrenia and epilepsy rarely occur together. So if an individual has epilepsy, it is very, very, very unlikely for them to also have schizophrenia, and vice versa. So the idea here being that, okay, maybe seizures are in some way preventing schizophrenic behavior. And so their conclusion in observing this was that, well, then we must start treating schizophrenia by inducing seizures. This is a very large leap to make. These researchers might have considered the fact that both schizophrenia and epilepsy are fairly rare disorders in and of themselves, so the likelihood of them co-occurring itself would be very rare. But they did not make that consideration. Instead, they decided that the best course of action would be to treat schizophrenic patients by attaching electrodes to their skulls and inducing seizures using electric currents administered to their brains, which is just as extreme as it sounds. Now, because this was introduced in the 1930s, this kind of a logical, or I don't know if it's a logical leap, maybe illogical leap, was pretty quickly accepted, and people decided to start using it to treat a wide range of disorders. But later on, research started to reveal that it can't really relieve things like anxiety disorders, and its value in treating schizophrenia is fairly questionable as well. So, despite the widespread use of electroconvulsive therapy, its effectiveness wasn't really shown. The major exception to this is that ECT has been really useful in treating severe depression. Now, the caveat here being the severe part. So especially in individuals who are suicidal or who are experiencing very severely depressive symptoms, ECT can show a 60 to 70% improvement rate in people. So if someone has severe enough depression, ECT can cause almost immediate improvement, and most people who go through the procedure end up improving. Now, current use of ECT, which is still fairly commonly used to treat depression, looks very little like what we imagine electroconvulsive therapy to be. It's not strapping electrodes to a resisting patient that you see in movies and TV shows. In modern ECT, patients are given a sedative and a muscle relaxant. It's a lot less of an aggressive process because, in this case, the patient would have consented to it. The shocks that are given last less than 1 second. They're as minimally invasive as possible, and they are intended to cause a seizure in the central nervous system. Once a patient has had this done, they usually wake up 10 to 20 minutes later. Maybe they'll have a little bit of a headache, maybe they're a little bit stiff, but it's not as dramatic and as violent as we see it portrayed in TV and movies. Now, despite this massive shift in how ECT has been used, and despite its sort of significant improvement for individuals with major depression, there are still some very strong critics of this therapy. And some of the major criticisms of this process is that the possibility of relapse is high. ECT is not a long-term solution. It is not a cure. It is a temporary treatment, and individuals who use it to treat things like depression will have to be repeatedly treated to have those symptoms stay at bay. There are potential issues been raised about the possibility for damaging people permanently. Things like permanent memory loss or permanent brain damage have been reported in some cases. And this possibility of permanent damage is a lot higher in individuals that have repeated treatment. So for modern ECT, individuals will only ever receive treatment up to 10 times, and that's sort of the cutoff that they've established where the risk becomes too high. And they also use MRI scans to make sure that there has been no permanent damage to those who have gone through it. So next, as promised, we're going to talk about psychosurgery. And this is a very dramatic type of treatment for psychological disorders. That's because psychosurgery refers to the process of removing or destroying parts of the brain. So, of course, this is one of the least used biomedical procedures because it is so extreme. And so a couple of these methods you may have heard before, things like the lobotomy, where you would where you would destroy nerve tracts that lead to the frontal lobes. Now, this process used to be conducted in patients who were uncontrollably violent or psychotic. And by severing these nerve tracts, it was breaking the connection between the frontal lobes and subcortical areas in the brain that are involved in emotion. So by severing that connection, it could calm those uncontrollable, violent patients. So this operation ended up severing the emotional input that our limbic system was sending into the areas of our brain in the forebrain that were connected with executive functions like planning and reasoning. And so, as you might imagine, when people didn't understand the process very well, having someone go from being a violent, aggressive patient to someone who was calm and controlled, it was a very appealing procedure. And lobotomies became very, very common. In the US alone, there were 50,000 performed in the 1930s and 40s, which is a massive number. But they soon realized that this process was causing massive nerve damage, and there were tons of side effects. So there were issues with mental and emotional functioning. Individuals would have seizures, develop a stupor. They had memory problems, reasoning impairments. They would develop listlessness. There were all sorts of issues that arose here. And with those antipsychotic drugs that we just talked about being developed in the 1950s, The performance of lobotomies dropped off dramatically because there was a safer alternative. And so people shifted away from this process. Now, that isn't to say that we no longer perform this kind of procedure. What we see nowadays is something that's just a little bit more controlled and refined. So it's called a cingulotomy. And it's basically doing the same thing, but in a very controlled fashion. So for this procedure, we would cut the fibers that connect our frontal lobe and the limbic system, but only in a very precise area, so very specific fibers, rather than the more blunt cut that happened with a lobotomy. Now, this is still a very rare procedure, but it can be used successfully, especially in cases of severe depression and OCD. So if it's deemed that the effects of the disorder are severe enough, then individuals may choose to take the risk and actually go through this process, despite any potential for side effects. Now, for our next section, we're going to talk about the mind, the body, and our therapeutic interventions that we've talked about so far. And so the idea here is that both our psychological treatments that we've talked about previously and the biological treatments that we're in the process of talking about, both of them affect brain function. The whole point of both of these types of treatments is to try and change our disordered thoughts, emotions, and behavior. And so maybe it's not as different as people might like to think, where our psychological treatments are all about talking and our biological treatments are all about changing our brain chemistry. In fact, there's a lot more overlap than we might have expected. So in studies that have used PET scans to image our brains and study where blood is flowing and how that blood flow changes both before and after treatment, there have been a lot of studies that show that both our psychotherapy and drug therapy, so psychological and biological treatments, show similar changes in blood flow in 3 different parts of the brain, which we can see on the next slide here. So this graph is showing reduction in neural activity. So the higher we are on this axis, we're showing more of a reduction. That's why they're in negatives here. So this would be probably a 20% reduction in blood flow. And then in the 3 different areas, we have our amygdala, the hippocampus, and the temporal cortex. And this red bar, the ones that are on the left side, are our psychotherapies. And the purple ones are the SSRI drug treatments. These are the worst colors possible for a graph, but there we go. And so this graph is showing us that in all 3 areas, the amygdala, hippocampus, and temporal cortex of individuals who were successfully treated for anxiety, they showed very similar decreases in blood flow in those 3 areas. So these bars are very, very close together here. So maybe it's not so different between our psychological and our physiological changes from our treatments.